Hi everyone, this is Melissa Shigoda from NNPHI, and I'm happy to welcome you to the second in our series of Community Health Improvement Capacity Building webinars titled CASPER Methods for Community Health Assessments with Matt Simon and Casey DeCosimo from the North Carolina Institute for Public Health. We're so glad you could join us for this exciting opportunity. Before we get into the presentation, I'd like to take a few minutes to provide some background on the series and also to introduce today's presenters. The purpose of the Community Health Improvement Capacity Building webinar series is to provide an opportunity for NNPHI member institutes to learn from their fellow institutes about how they've selected and adapted specific tools and processes for their community health improvement initiatives. This webinar series grew out of the work of the Capacity Building subgroup of the Community Health Improvement Work Group that started meeting this past fall. For more information on that work group, you can contact me via email at mshigoda@nnphi.org, and that's entered into the chat box too if that's easier to copy and paste. The first webinar in this series featured Dr. Samantha Francois from the Louisiana Public Health Institute sharing about the rapid regional community health assessment process they used across the 4-state Gulf Coast region impacted by the 2010 oil spill. She also shared about how LPHI collaborated with the Florida and Mississippi Public Health Institutes to support ongoing community health improvement efforts with their local health departments. The archived webinar of that presentation is now available on NNPHI's website, along with a written case study that includes some additional detail. On today's webinar, Matt Simon and Casey DeCosimo will share with you how they adapted the Community Assessment of Public Health Emergency Response, or CASPER, methods for community health assessment data collection. They'll talk about why they chose this method over other data collection methods and how they developed a handheld app to facilitate the data collection process. They'll also get into the nitty-gritty of the steps involved with implementing this process and using the tool, the staff capacity needed for the process, and the lessons they've learned. Throughout the presentation, we'll stop a few times to ask for questions or comments from participants, and at that point I'll unmute the lines so people can ask their questions themselves. But if we have any problems with feedback or background noise, I'll leave the lines muted and participants can enter their questions into the chat box. We'll also have time at the end for final questions and discussion. If you have any technical difficulties, you can contact my colleague Liliana Johnson. She can be reached via email at ljohnson@nnphi.org, and you can find her email address in the chat box as well. So before we get started, I'd like to introduce Matt and Casey. Matt Simon is a research associate and GIS analyst in the Research and Evaluation Unit at the North Carolina Institute for Public Health. He has a master's in physical geography from UNC, a graduate certificate in field epidemiology from UNC, and he's also a certified GIS professional through the GIS Certification Institute. He is responsible for providing technical assistance and guidance to state and local public health agencies with data collection and spatial analysis projects related to emergency preparedness and other community-wide or regional public health concerns. And Casey DeCosimo is a research associate in the Training and Technical Assistance Unit of the North Carolina Institute for Public Health. Her current responsibilities include providing training and technical assistance for community health assessments and developing distance-based and face-to-face training curriculum for a variety of public health topics, including disease surveillance, field epidemiology, and disaster preparedness. Prior to joining the Institute, Casey worked at the Chattanooga-Hamilton County Health Department in Tennessee, where she has experience working in the areas of population health assessments and crisis/emergency risk communications. Casey has an MPH in health behavior and health education and a graduate certificate in field epidemiology from UNC School of Public Health. And with that, I will turn it over to Casey to start the presentation.
Hi, Melissa.
Casey, are you there?
Okay, thank you. Can you hear me okay?
Yep, can hear you.
Okay, great. Well, thank you everyone for joining us this afternoon, and thank you, Melissa, for the introduction. And as I mentioned, I'm Casey DeCosmo with my colleague Matt. And before we get started, I wasn't sure if you're familiar with the North Carolina Institute for Public Health and what our institute's area of focus, what they are. But basically, we're housed within the University of North Carolina Gilling School of Global Public Health, and we really try to translate research into practice and to really serve as the bridge between academia and all the resources that we have available here to our public health practice partners in North Carolina and beyond. And we have three core functions at the Institute here: training, research, and technical assistance. And Matt works mostly in the research technical assistance side, and I'm part of the training and technical assistance side. So Melissa provided an overview of what we're hoping to share with this webinar today. These are our learning objectives. So we are hoping to be able to describe the community health assessment, or we call it the CHA process in North Carolina, which I'll spend a little bit of time covering. And then Matt will describe some background on the community assessment for public health emergency response, which we call in this presentation CASPER, and those methods, explaining some background for those, and then also how it can be used for community health assessment or CHA data collection. Matt will also discuss lessons learned using these CASPER methods and next steps, including the development of the mobile application. And as Melissa mentioned, throughout the presentation we'll pause for some questions. Before we get started, we wanted to launch a little poll, and we wanted to find out how many of you have participated in a community health assessment or needs assessment or the improvement planning process. So we'll just give you a second to fill that out. Okay, I think everybody's done, so let me go on to the results. So, 83%. Yes. Yeah, so the majority of y'all have participated in the health assessment process, and that's good for us to know. We just wanted to kind of gauge where folks are. And North Carolina has a long history in this process and a very structured process that they follow. So we'll kind of briefly discuss some of that information, but knowing that you all, the majority of you, have participated in these processes before, and we'll take our discussion and kind of focus on data collection methods that we have used. So let me advance here. As far as our experience working with community health assessments, the Institute, since 2010, we've provided technical assistance to local health departments in over 17 community health assessment projects covering about 20 North Carolina counties. 5 of those projects we have actually worked closely with hospital partners, which is an exciting venture for us. We hope to do more of that. And I'd say so far our assistance with health assessments has primarily included data collection, analysis, prioritization, and reporting. We have worked with health departments in providing overall coordination of the entire community health assessment process and doing facilitation for them, especially if they don't have the staff capacity for it. Matt and I personally have not done a lot of work with improvement planning or action planning, and that's definitely an area we're hoping to build capacity in and provide assistance in the future to our public health partners. But this is just a sense of kind of our experience and what we've done so far in North Carolina. So I mentioned that North Carolina does have a long history of conducting health assessments. Some of you may be familiar, some of you may not, so I just wanted to share a brief information about the history. But community health assessments, formerly known as community diagnosis, have actually been conducted in North Carolina with public health agencies since 1974, which is pretty amazing. In 2002, with funding from the CDC, the North Carolina Division of Public Health and the State Center for Health Statistics partnered to build capacity among public health agencies to conduct community health assessments and began administering the program through the Office of Healthy Carolinians, is what they called it. And through this process, they kind of developed a formalized stepwise process for conducting health assessments and developed a guidebook. In 2005 and 2006, from Homeland Security funding, which Matt will kind of provide some more background on that later, several counties started adapting rapid needs assessments, that framework for community health assessment data collection. And in 2011, resource cuts actually led to the closing of the Office of Healthy Carolinians at the State Division of Public Health. And to our knowledge, there's no statewide training for community health assessments provided to local health departments and staff, although there is some technical assistance available at a regional level through the Office of Public Health Nursing, which now kind of oversees community health assessments in North Carolina since they are required. And also, with the closing of that office, they updated the guidebook, which is available online. It's a fantastic resource if you haven't checked it out already. And we also have that link listed in the resources section of this presentation. So I talked a little bit about the history in North Carolina, and I just wanted to mention briefly about the requirements as well. So North Carolina community health assessments are required for public health accreditation, for local public health accreditation in North Carolina, and they're required to do those every 4 years. However, with the advent of the Affordable Care Act, the Division of Public Health here has now allowed health departments to be in sync with hospitals and do a 3-year cycle if they choose to do so. And I think a lot of health departments in this state have moved to a 3-year cycle. And then for interim years, because of the North Carolina accreditation requirements, health departments are still required to submit a state of the county health report. I always get that mixed up, or we call them the SOX reports, during those interim years, which provides kind of an update and progress based on the priority areas identified in their last health assessments. They actually have to report updates on goals and objectives that they developed from the last assessment. So this is just kind of framework and background for you all. I think it's very helpful to note because in North Carolina the process is very prescriptive, and the Division of Public Health developed kind of an 8-step process shown here, kind of starting with establishing a community health assessment team all the way to developing community health action plans and reporting all of that information back to the state. What's unique about North Carolina's process, which I had done health assessments at the health department in Tennessee, so it's very different. I found coming back to North Carolina is that health departments are required to collect new data from the community as part of the community health assessment process. And this is something that's kind of unique, and we've really found that technical assistance is needed in this area specifically. And so we'll be using this presentation to kind of focus on phase 2, collecting primary data, and how we've assisted communities to do that. So just a little bit about the primary data collection phase. Local health departments are required in North Carolina to collect data through 2 primary ways: community health opinion surveys, or small group discussions or focus groups. So if they don't do a community health opinion survey, which should be representative of the entire county population or region, then they do small group discussions, which they'd have to do at least 10 in their county if they're not doing the survey. They have the option of doing key informant interviews, and this process, roughly, depending on the community, takes 3 to 5 months for data collection and analysis. So the majority of counties in North Carolina opt to conduct the community health opinion survey as their primary data collection strategy. And this is a survey where adults are eligible, have a chance to be selected. There are approximately 50 questions, and the goal is to really collect information on a county level that can't be obtained from other sources. So, for example, if your county participates in the behavioral risk factor surveillance system, you may be able to get indicators on diabetes prevalence or obesity prevalence, so you may not want to focus your survey on obtaining duplicate information. But in other communities, particularly rural communities, they don't have access to much county level data as far as chronic disease prevalence or health behaviors, so they may focus their questions on that. And some of the topics that are often included in these surveys, and the Division of Public Health does have a English and Spanish version of the survey in their guidebook that anyone can use. They focus on community concerns, services needing improvement, healthcare access and barriers to accessing healthcare, health conditions and behaviors, and emergency preparedness. We got a quick poll for you again. We just wanted to ask you all if you've had a chance to participate in surveys like this before, or have gone door to door to do this type of data collection work.
Alright, looks like we got all the responses. This is Matt, by the way. I'm going to take over for Casey now. So, looks like the majority of people have not gone door to door. And I guess that's kind of surprising considering how many people have taken part in CHAs, but like I'll talk about, there's lots of different ways to collect data for this. For those of you who have gone door to door, or for those of you who haven't, going door to door to collect this type of information is a lot of work. So why do we do it? Mainly, we have 2 primary reasons. We think that we get more representative data and a higher data quality. When I say more representative, the key point there is that this type of data collection is accessible to everyone. If you were to do a cell phone survey or a phone survey, not everyone has that type of, you can't always get in touch with everyone that way. You could do an internet survey, not everyone has access to the internet. So this type of data collection is accessible to everyone. It's also generalizable to your area of interest because everyone is eligible to participate. We also think you get better data quality, and what I mean by that is a couple things. Higher response rates. It's a lot harder to say no to someone when they're actually at your door. Close the door in your face. It does happen, but it's a whole lot easier to hang up the phone on someone or just ignore that email requesting you to complete a survey. So we get higher response rates, and in turn, the likelihood that bias exists in our data is lower. We also get more complete data, so we're able to fill in the gaps, provide clarification on questions or wording, and there's less missing data overall. So that's another plus for doing it this type of using this method. Finally, it's really a boots on the ground opportunity to show in a tangible way that the health department is out there, or public health in general is out there and cares about the community. And this in turn can, improve the public image of your organization. So stepping back just a bit, actually I'm going to skip this and come back to it. So what is CASPER? Why do we use this sampling approach? CASPER, as Casey stated, it stands for it's an Assessment for Public Health Emergency Response. They're basically face-to-face interviews. They're conducted with randomly selected households, typically after disasters. And it's a way to determine the health status and basic needs of a community in a quick and low-cost manner. It's been adopted pretty easily for this framework. It was developed really in the 60s and 70s by the World Health Organization, and some of you may be familiar with the Rapid Needs Assessment, or the EPI method, the expanded program on immunization. This was a program whose goal was to make vaccines available to children throughout the world. So they developed this method to quickly assess how well they were doing. I'm going to go back to this one now. So why CASPER? Why Rapid Needs Assessments? And just kind of take a step back and talk a little bit more about background in North Carolina and how this method has come to be. So in 2004, there was preparedness funding in the state that the Division of Public Health used to initiate a program that disseminated GIS software, GPS equipment, and training on how to implement this method, so how to assess public health needs after a disaster. So they distributed equipment, trained all the regions, the public health response teams in the state. But as with most things, if you don't use the training, if you don't use the equipment, you kind of lose that knowledge, you lose those skills. And so what happened was a couple counties kind of had the knowledge. They helped people out with technical assistance, but they couldn't help all the others when they needed help with this type of a method. When they decided, well, we could use this for the CHAs, we could use this to collect the primary data. So in 2009, we formed the Spatial Health Assessment and Research Program here at the Institute for Public Health to kind of fill that gap, to help out the counties that needed assistance. At this point, the technology was getting pretty old. They had old GPS units. The sampling software was outdated. So we updated things. We bought a new set of GPS units. That's what's shown here on the screen, the mobile mappers. And really, I mention all this history in detail just because this is what really established the importance of using this statistically valid method in the state to collect health data. And this is what's led to quite a few referrals and continued work in this area. So the actual sampling method that we're using is what's called a two-stage cluster sample. And clustering just involves basically breaking up your area into geographically distinct areas. It could be villages, or it could be neighborhoods or families. In the U.S., we use census data because it's readily available. In the first stage of the two-stage cluster sample, you randomly select clusters. These are population weighted, so the probability proportionate to size sampling. The larger clusters that have a greater population have a higher probability of being selected. So that's stage one. We randomly select clusters. Stage two, we randomly select within each cluster random interview locations. And this, as I mentioned before, it's been used in public health assessment since the 60s. It's a popular method to implement. CEC has adopted it, and they call this now CASPER. So again, why use this method? Basically, clustering is an alternative to simple random sampling or convenient sampling or stratified random sampling. You could collect this information. You could implement a survey using a simple random sample. If you had a list of all the residents in the county, that's not always easy to come by. If you did have it, then you could select a reasonably sized sample and then drive out to all those locations and conduct the survey. Or you could mail out a survey, a form. Like the reasons I mentioned earlier, we like to go door to door. If you ended up having to drive to all those places, clustering just really saves time. You don't have to drive to as many different places. Convenient sampling is another valid way to collect this type of information. So that might be standing at a health fair, conducting surveys, or even sending out an email link to, broadcasting it to a bunch of people. And it's a totally valid way to do it. You won't be guaranteed representative data in the end. You don't know who's going to actually take the survey. There's some bias inevitably that exists there for the people who want to participate. And you have to collect a lot more surveys for it to be valid, to get the same type of accuracy as you get doing cluster sampling. And that really gets to the second bullet point up there, which is it's a validated method, this cluster sampling. It's been used for many years and produces reasonably valid results that with 95% confidence we can say the true value is plus or minus 10%. The final reason we use it is that it's an accepted method in North Carolina for accreditation. So that's a pretty good reason as well. This just kind of shows what a cluster sample might look like. Stage 1 up there shows the red areas. They're kind of spread throughout the county. So that is our 30 census blocks that we've selected. And then stage 2, we randomly select 7 households within each cluster. And this is how we get a sample size of 210. 30 by 7 is kind of the magic number. It's what tends to work. But it's not the only way to do it. We've in many cases used 40 by 5, so we select 40 census blocks and 5 interviews per location for 200 surveys. We found this works better in rural areas. Some census blocks only have 10 households, so you're going to be hard-pressed to get 7 interviews. Another strategy for that is to aggregate up and use, instead of blocks, the next geographic unit, which is a block group. Block groups have hundreds to thousands of people in them, as opposed to blocks, which are pretty small. Here's just another example of what that might look like on a county scale. This is a survey we did recently in Pender County, and you can see that the blocks are spread out throughout the county, so you get a pretty good geographic representation. And when we look at the data afterwards, we look at the demographics of who responds. It almost always lines up very well with the demographics of the entire county. So CASPER really is a process. It involves all these steps shown on the screen, starting from developing the questionnaire to preparing the survey, all the way down to reporting. And we're going to share some of the lessons we've learned throughout the presentation here. We could give multiple webinars on just how to implement a CASPER. But I want to encourage you to check out the toolkit here, which was shown on the screen. This is something that the CEC has developed. And it's a guidebook. It'll walk you through step by step if you did want to use this type of data collection method. It has good resources in there, including some sample forms. But again, keep in mind that this is geared towards disaster response, so sample forms might not be as appropriate. So I feel like this might be a good time to stop and just we can unmute the lines and see if anyone has any questions. Does the sampling method make sense? Is anyone else working on a CHA that has a primary data collection component where they might see this as a useful method to implement?
The conference has been unmuted.
If there's no questions, that's fine too. We can move on. We'll be stopping again here shortly. So I'll just carry on.
The conference has been muted.
Inevitably, was I muted that whole time? No? Okay. One thing we find when we present this method to steering committees is that there's always at least one person, usually a county commissioner or someone who doesn't really buy into the process, like why are we spending all these resources going door to door. Some people are just skeptical of the assessment process in general. And they always want to know, well, you've done this many times, but what are the results? What impact has your work had? And there's tangible and intangible results. And I find it's not really an easy question to pin down. But if Casey's in the room in that situation, I usually look to her and have her answer it. But as many of you know, you can't have good implementation without a good fact base, and that's really what this type of work provides. Tangible benefit is that at the end of the day, we have a document and data to compare against. It's our baseline, and it's a baseline of a variety of health needs that you can use moving forward, and it includes local level data that is otherwise unavailable. Like Casey mentioned, the behavioral risk surveys are for smaller counties in particular. You might not have that level of data available for you. There's also intangible benefits to conducting this type of work. First, you're creating a visual presence on the ground. We had a public health nurse who helped us in Forsyth County recently, who came back after a long day and of door-to-door surveying, and she said, this is really grassroots public health work, boots on the ground. But it can also be an eye-opening experience for steering committee members or other CHA stakeholders who get the opportunity to see parts of the community they otherwise don't see. Again, it's a random sample. You're drawing on census blocks from everywhere. You're not just visiting those areas that you're used to. So you might see living conditions that you're not accustomed to seeing. It can be kind of shocking, eye-opening in that regard. But it can also be fun. You can make connections with your community. And so those are some of the intangible benefits that are kind of hard to put a finger on. But the final result that I'm going to mention here is that we hope that engaging health departments in this type of work, that we're building their capacity to conduct some of this on their own, or to feel comfortable using this type of data collection method. We offer trainings on interview techniques and sampling and data collection, so hopefully at the end the capacity for the health department to do that will be better. Another outcome of this process is that the data we collect is actually used to determine the priority areas. And in North Carolina, the community opinion, the opinions of the community members are really driving the direction of the health assessment. And this is just an example of a word cloud that Casey put together, which selected the priority areas from all of the counties in North Carolina that were on the 2017 assessment cycles. So you can see that there's a common theme across a lot of these health departments. They're priority areas. Obesity right off the bat draws your eye, and this type of information is being used at the state level to say, well, maybe we need to collaborate for those counties that have this as a priority. Is there a collaborative impact model that can help address these things? We also recently followed up with 10 of the health departments that we provided services to see how they've used the CHA data that we helped them collect. We were interested in seeing what kind of impact the work had on their CHA and what barriers they experienced. I don't want to get into it too much. I think I will share just this one slide on the impact. So when we asked them, to what extent do you think the CHA has impacted your health department and the community, you can see that across the board there, it was used for many different things. One thing that strikes me is the again, it's a baseline of data. It's a resource to draw upon, and for writing grant applications, you can say that this is a validated statistical method. This is, this is our take on the community. But so there's lots of different ways that the CHAs have been implemented. So good to have that. Okay. So what now? We have these positive results that we've seen. That we feel like the data is being used well, but our technology is aging at this point, and learning the method and maybe using the equipment isn't as easy as it could be. So just last year, we decided that we would join the 21st century and build our own app. In another evaluation we conducted in 2010, we talked to local health departments throughout the state about their use of CASPER, and the majority of respondents indicated they were very likely to use CASPER again, but that lack of training and equipment were frequently cited as barriers to using CASPER. And so that's kind of a big reason why we decided to take this leap from the existing methods of doing this on handheld GPS units and mobile GIS software. Is that it's hard to use. It's not intuitive. So it's quite an undertaking to develop an app, and we put a lot of thought into it ahead of time. Like, can we just use something that's out there already? There's so many data collection apps out there, like Qualtrics or SurveyMonkey actually now has a mobile version. They didn't when we started. ArcGIS also has an option at the time that would have been great, but our school was still trying to sort out the licensing. So we had the federal money to do it, so we decided to go ahead and build something that we thought would fit our needs. Like I mentioned, the GPS units were aging. Tablets, had clear benefits. They're much cheaper than the GPS units. And they're more intuitive. It's easier to use. Almost everybody has a smartphone, so we wanted to develop something that health departments could use with equipment that they might not have to buy. So what we did was we finally settled on kind of a mix of things. We used EpiInfo, which is the CDC's open source and free statistical software. So they have a desktop version, and then they recently developed a mobile version, and that's what's shown on the right of the screen here. So what we did was tack on the map view there with the arrows pointing, and that map view allowed us to incorporate the spatial data from the cluster sampling. So we developed a set of web and server tools, the project management dashboard for CASPER cluster sampling. We're still working on the name. I think that's a bit of a mouthful. And what that allowed us to do is essentially upload our spatial data from the cluster sampling, and then it allowed the project manager to monitor where the teams were in the field. And the way the app works is, here's just a screenshot of when we used it recently in Durham County. The outline that's in blue right now is the selected cluster. Those blue dots are our survey sites, so you can see the address there. 3720 Dairy Pond. It shows the status of the point, if it's completed or incomplete. And if you tap on the point, then it brings up digital forms. So the forms you can build in EpiInfo and upload them to the app. And then everything's stored electronically. And I had a slide in here about why paper versus digital. I think the benefits are fairly obvious. There's definitely drawbacks. Paper's easy. There's no technical difficulties with paper, but there's a lot of benefits to being able to analyze your data in real time, and you get cleaner data, less data entry errors. The other component of this was the ability of the project manager to see where everyone is. So the red triangles on the screen show where the surveyors are in the field, and then you have the X's and the blue dots show where the surveys are completed or still in progress. So we took this on the road and tested it out in both urban and rural areas, 5 different community health assessments. last summer and then this spring. And we also tested it out in a disaster recovery survey. We conducted over 1,000 surveys with 165 teams over 20 days. We did evaluations throughout this process to kind of gauge user feedback and get improvements, collect improvements, and we're basically taking all of that feedback and developing the next version of this thing. The next version will include the ability to collect data offline. The version we had was a little glitchy in rural areas where cell coverage was poor. So we're going to add that ability. We'll also, currently it only works for one user at a time, so one project manager. We're going to add that ability for multiple people to use it. It will also include the site selection that I mentioned earlier, which currently resides in expensive GIS software that isn't easy to use. So we're going to build that into the website. So you just go to the website and say, I want to conduct the survey in this county, and it'll push the spatial data to your app. And we're going to build in some real-time analysis so that the project manager can see the results as they're coming in and adjust things if they need to. And the final output of this will be a public release. We are still figuring out exactly how we're going to release it. Probably will not be on the Play Store. This is an Android-based app. We're probably going to try to control the distribution of it a little bit more so that people have to go through a training series so that we know that they're using the sampling method legitimately, or that they're doing it the right way. So that hopefully will be releasing it to the public in the spring of 2015. So maybe we can open it back up for questions at this point. And just so everyone knows, I'm going to talk about marketing after this and lessons learned, cost, and resources. So we're just about done. If anyone has any questions, feel free to chime in.
The conference has been unmuted.
Hi, this is Steve White from the Oregon Public Health Institute, and I just have a couple of questions.
Yeah.
The first has to do with, I guess maybe the type of questions or information you're gathering. I think at one point you mentioned that, one of the nice things about this is you can actually get people's opinions on what they sort of see as primary health issues for their community. But maybe you could just talk a little bit more about the other information that you get here and how it relates to BRFIS data or other existing data sets that are out there and are typically used for community health assessments, and sort of, maybe a couple of sub-questions related to that. How does this align or not with it, and have you used this to sort of ground truth some of the more sort of sort of broadly gathered data such as BRFIS data?
Okay, yeah. So we have included some questions that are directly from the BRFIS, and it does line up pretty well. We do try to keep the survey to a minimum, though, so if it's possible, if that data is already available and it's recent enough, then we say don't include it. We ask questions about quality of life, so how they feel about access to health care in the county, whether or not they feel that they feel safe living in their county, and we ask them about community issues. We often give them a list of things and say, if you had to pick 3 things that you think most affect the quality of life, what would they be? We ask them about services that need improvement. Casey mentioned that. And we do also ask personal health questions, so those might be the things that would show up on the national surveillance. And typically counties will use the same questionnaire for the most part in North Carolina. There's a standard document that the state has distributed or has on their website. But they'll typically also add questions when they want. They'll ask questions about food security, for example, or they might ask questions about a certain county might have a high suicide rate, so they're going to ask some questions about that. do you want anything to add to that? Or?
Yeah, I think that's about it. Does that help you, Steve?
Yeah, definitely. I think that helps a lot. My other question was just about the app itself and whether or not it's possible to download shapefiles, or how would you otherwise sort of bring that information together with like ArcGIS, which I think a lot of agencies use for doing mapping.
Mm-hmm. So the input, the spatial data input into the app right now is KML, the Google Earth, or the open source KML format, and then the output is really, it's an epi-info. There is no spatial data output, but there's an option that we always put in there. We build in a button to capture the lat long, so then you can map those points. But usually we don't map the results because it's such a small sample size.
Right.
And our IRB won't allow us to display those results below zip code level. But the next version, basically, that's going to be kind of self-contained. Like you won't have to supply a KML. You won't have to have access to GIS software. It'll be all on the website. It'll just access the census data for you. It looks like there's also a question on who does the door-to-door sampling. Isn't it expensive? And that's such a good question. And that's something we're going to talk about next on Lessons Learned. But the short answer is we rely on volunteers, and that can be challenging because it would be expensive if we had to staff this ourselves. Any other questions before we jump into what we've done for marketing and talk about lessons learned? All right, well, let's carry on.
The conference has been muted.
So as I mentioned in the past, a lot of our work we've relied on referrals. So because there's been this history in North Carolina of cluster sampling being a validated method to collect public health information like this, but there hasn't been the capacity. There haven't been people to provide the technical assistance. We've relied on people that we've worked with before referring us to other counties. But we have also developed some materials. The flyer shown to the right is one example that kind of breaks down the different tiers of service that we supply for the community health needs assessment. And so that includes basic services, which we consider primary data collection. So that's the health opinion survey that we've been talking about this whole time. But we also offer key informant interview or focus group support and assistance with secondary data collection. Or full service, do the entire assessment for them. We recently, just last year, was our first marketing effort, and we sent letters to the health directors. So the health directors that we knew were due for their assessment, we sent them a letter just saying, we know you guys are due. If you would like to talk to us about how we can help, give us a call. We did that again this year, but we also included the flyer to the right. But we've been unclear on really how to pursue the hospitals. The hospitals that we have worked with, they're new to this process, so they don't really know necessarily. But the people that we have been in touch with in the hospitals have mostly been in the communications departments of the hospitals, which I think is interesting. But that's pretty much it we've done for marketing. So just kind of wrapping things up. The lessons that we've learned through the years are that primarily CASPER is an effective method to collect primary data for your CHA. It can be used in non-disaster settings. If you do decide to take on this type of work, plan early. It can be done in a shorter time frame. Remember, it is based on a rapid needs assessment framework, but 3 to 5 months is really the comfortable time frame to get something like this done. We typically say to set aside 3 to 4 days for surveying with at least 10 teams per day. And as I mentioned earlier, we rely on volunteers. and that's tough. I'm actually going to talk about that on the next slide, so I won't get into that yet. If you do take this on, the staff capacity required, it's good to have someone with strong data skills. Epidemiologist is ideal. A GIS specialist is helpful. Volunteer coordinator might be the most important if you are relying on volunteers, because it can be a lot of work for that person. And we've also found, if you are recruiting help for these door-to-door surveys, that people who routinely do home visits, they tend to be the rock stars, the ones who can really are really successful out in the field and are comfortable going door-to-door, or are comfortable approaching people. Public health nurses are also great. Nursing is the most trusted profession based on some survey. Those are the type of staff that are necessary. But that can also just be one person. One person can pull it off to do it all. Depends on what you have, what's available to you. So as I mentioned, we have learned a little bit in this process about how to overcome barriers. The biggest challenge by far is volunteer recruitment and training. You really never know who you're gonna get, the quality of the participant. So it's really important to have a good 2.5 to 3 hour just-in-time training if you're going to do this type of work. The CASPER toolkit I mentioned earlier has some good resources, or has a good outline for what to include in that type of training. But we always talk about field safety. We talk about interview techniques. We talk about the sampling method. How you select the first person you go to in the home. How do you continue on from there? And give them plenty of time to learn the technology, to learn the equipment. We have tried in the past to recruit like 10 team leaders and say it's up to you to find someone to go out with you, and that can work pretty well. But it's also important to really consider who you are pairing up together. We like to pair local people with out-of-towners if you have both participating. A local person's going to know how to get around their area. They're a friendly face. People might recognize them. You send two college students out together who aren't from the area. They might do well, but our experience is they can struggle. Especially with the technology, it's nice to pair up, to split up the students, because they often get it. The questionnaire development is another a big barrier that we've run into. Like I mentioned, the state has a template of about 50 questions, and most counties start with that template, and they make some modifications. But I would just highly encourage you to be involved in the questionnaire development process early on, and try to keep it to 50 questions or less, so that the interview doesn't take longer than 15 or 20 minutes, because after that you're running into survey fatigue. And then the other lesson learned, I think, is one that we're still learning, and I don't know, maybe there's people on the line who might be able to share some lessons that they've learned with working with hospitals, but it can be a challenge because, like I said, they're new to the process. So I know that we're getting short on time, so I'm going to jump through to some other stuff. We were asked to share the overall cost of what this work takes, and to pull off the survey, we are charging about $12,000 to $15,000, and that covers our staff time, some of the training materials, the equipment upkeep to a certain extent, but that's pretty much our staff time. Not we don't reimburse people for mileage. We reimburse our students for mileage if they come out, but we don't have a mechanism for reimbursing the county staff that we work with, so that's a hidden cost, and of course it doesn't include any other staff time. and it's different with every county that we go to. Some counties do have a real strong support from their community. They come out, we'll field 15, 20 teams, and collect the data with no problem in 3 days. Other counties, it'll be a struggle to get 5 teams out every day. You just never know. But so that's roughly what it costs to pull off the survey, and that also doesn't include all the equipment and software. So hopefully with the app it'll be a good bit cheaper. For a full service CHA, the cost is roughly we're 60 to 90,000. It includes the primary data collection, secondary data collection, facilitation of the steering committees, going to and assisting with the community forums and writing the report. There's lots of resources that we'd like to share. DPH, although the Healthy Care Lineage is gone, they do have a lot of that information still online, including the questionnaires in both English and Spanish. CDC's CASPER toolkit is their website. And then, just as an example of one of the assessments we worked on recently, the 2013 Wake County assessment from last year can be found at that link on the bottom. And I have another couple resources. If anyone's interested, please feel free to contact me. The Survey Site Selection Toolkit that was developed back in 2006. It's old ArcMap software, but it still works on some of the older versions. So there's also some training resources available through our website. The NCIPH training website. If you search community assessment, a couple will come up. So that's a potential resource if you wanted to learn more, and also if you wanted to learn more about GIS mapping, there's also that option. We're coming in right under the wire. It's 4:59. It's probably a good time to open the line back up if anyone else had any last questions. This is our contact information, so please feel free to contact Casey or myself anytime. We're happy to share.
The conference has been muted. The conference has been unmuted.
Thanks, Casey and Matt. Does anyone have any final questions or thoughts before we wrap up? All right. I'll just some quick housekeeping things. The presentation slides with the links to the tools from today's webinar can be found on Dropbox. And we also have a quick evaluation that we're asking you to help fill out so that we can improve the series going forward. Our next webinar will be on Wednesday, August 6th at 3 p.m. Central Time, and will feature Sarah Hartzig and Jennifer Woodward from the Kansas Health Institute speaking about their CHIP Collaborative Handbook and CHIP template. And finally, a huge thanks to Matt and Casey for sharing their experience today. And all of these wonderful tools. Thanks, everybody.
Thanks.
Thank you.
Thank you.
Hey, Melissa?
Hey.
Do you mind? Oh, trying to access the evaluation. Do you mind putting it in the chat?
Oh, can you not see it in the chat?
I'm looking at it on the Ready Talk now, so that works. Thank you.
Okay.